when you're really busy and you've got to get people through the system, a lot of times this lovely lofty goal of transparent, engaging, and interactive conversation, there's not enough time for it to really happen.
Right.
And I know for a fact, because I would ask the doctors when I worked in a busy retail pharmacy, some of them I would ask, and if I felt like it or if I thought I knew them enough, like, why did you prescribe that antibiotic if you knew it was a virus? He's like, listen, I just had to get them out the door. They wanted something.
Right.
The way they would tell me this is they wanted something. So in giving somebody what they want, they felt like that helped them. That made them feel better. It's kind of like the placebo response, is it not?
Right. Yeah.
So even though they don't maybe like the placebo response, they certainly were taking advantage of it. But long term, and then I think, well, the side effects for all of us for overprescribing antibiotics, bacteria being resistant for others, and also the killing off your good bacteria and all of that. And then I think, okay, well, then you could go into that, but that's a whole thing.
Right.
That's a whole thing to get into with somebody about why I understand you want a Z-Pack, but you have a virus.
But that's the point too, is that it shows how in order to try to improve the system, they're missing the boat. Because patient education is really the key to better doctor-patient interactions and the whole system working better. But the system doesn't allow it.
It doesn't allow it.
So they're trying to figure out other ways in order to try to make that happen.
They're trying to hack it.
Exactly.
And there's no hack for a good relationship.
No.
You are listening to Take on Healthcare with Ted Suzelis, naturopathic doctor and pharmacist Mary Sheehan. Have you ever wondered what happens to the patient satisfaction surveys you filled out? You probably assume that your input is used to make the healthcare system better. But what if these surveys may actually make things worse for you and your doctor? On today's podcast, we take on patient satisfaction surveys.
So we're taking on patient satisfaction surveys, which, I don't know, in my career has been like the bane of my existence. A few months ago, I got the idea from LinkedIn. Dr. Corey Aman had posted this great post, which I think was referenced in some of the research that you did.
Yeah.
And one of the things, well, first of all, what does he call it? Killer patient satisfaction scores. And he says, it's Dr. Corey Aman, we all would love to get higher patient satisfaction scores. Many providers have their bonuses directly tied to these numbers, which is true. That happened to me too. But what if these higher numbers killed our patients? And I'm like, what? And then he links some studies. Studies have shown a 26% increase in mortality in the most satisfied.
Right.
I mean, that's like crazy. And then he was talking about, is this widely known to the executives, the ones that create it? Because the doctors, we on the front lines, we're not creating these satisfaction surveys.
Well,
we
no.
really don't like them.
You're just putting up with them.
Exactly. And these things make us very sad. And then he also goes on to also quote from studies, higher patient satisfaction also means more hospital admissions, 12%, more hospital costs. They can't be happy about that, 8.8%, the C-suite, and more prescription drug expenditures, 9.1%. So we're going to break that down. So that's what inspired the post. And what are your initial thoughts on the post? I know you've said because you don't practice within the allopathic system, it doesn't really affect you
as much, yeah.
But what did you think about it when you first started talking about it?
Yeah, I guess I was a little naive in not understanding the total significance of it.
Oh, okay.
I did not realize until you forwarded me that post that there was anything with bonuses tied to and everything. So I really was shocked that it was something that was just so widely pervasive and so important to the medical systems.
Yes. Yeah, it is shocking because can you imagine being a traditional doctor and all you want to do is take care of patients and you have this you're with your patients, you're in the zone, you're trying to come up with the best solution, you're trying to diagnose, prescribe. But then in the back of your head, you have to have this whole other set of thoughts. Like, is this patient going to be satisfied with this? And what are they going to check on the box?
Yeah.
That would make me sick in my soul.
Right.
Well, it has made me sick in my soul. Like as a community pharmacist, when it was a bigger deal back in the day, it's like, wow, I just want to focus on my job. Why isn't me doing a good job good enough?
Yeah.
Why is this on top of it? And as we'll get into, there's some good things about it, and we'll talk about that.
Right.
But it just seems to me like in our research, there's definitely more bad things.
Well, and it's one of those
it.
things that you're going to see all different pieces of it. And some of the negative things we talk about is not things that are happening to the majority.
Okay, that's good to keep in mind.
Right. It's not everybody that's having these problems and working to try to do the best they can for the patient surveys.
Yes, that is a really good point. And what I like about it too, like to talk about it for people, is just what you said. To know what is influencing your healthcare system.
Right.
So many things influence our healthcare system. And this is just another layer.
Right. And when you think about it, this is top down. So
yes, which is
it's
part of the problem.
Hospital systems, because they're so big, this is their one metric to try to understand what's going on.
That's fair.
And yeah,
that's fair.
So there's only so much they can do. And then, of course, as we're going to talk about later, that Medicare and Medicaid got into this where then reimbursement is tied to these surveys because the government wants to focus on how healthcare is doing and trying to use their influence to try to make things better.
Yep. And do they? That's the question. All right. So we're going to start with the ways in which patient satisfaction surveys make healthcare better for everyone.
Well, let's talk about some of the comments.
Oh, yeah. Let's talk about the comments.
Yeah.
The comments on the LinkedIn post?
Right.
Yes.
Right.
Oh, yeah.
Yeah. So one of my favorites was a comment. Somebody was responding to Dr. Amon's comment where he said, we prescribe 0 narcotics and pretty strict on antibiotics as well. And this person, in their astute comment made the association that in order to be pretty strict on antibiotics, you also need to have transparent, engaging, interactive, and respectful conversations as to why the patient may not need those treatments. And that's a huge issue there as far as looking at over-treating.
Yes, which is a downside.
Yeah.
And I guess too, when I know the comment you're referring to, when you're really busy and you've got to get people through the system, a lot of times this lofty goal of transparent, engaging, and interactive conversation, there's not enough time for it to really happen.
Right.
And I know for a fact, because I would ask the doctors when I worked in a busy retail pharmacy, some of them I would ask, and if I felt like it or if I thought I knew them enough, like, why did you prescribe that antibiotic if you knew it was a virus? He's like, listen, I just had to get them out the door. They wanted something.
Right.
And it wasn't, and it was that the way they would tell me this is they wanted something. So in giving somebody what they want, they felt like that helped them. That made them feel better. It's kind of like the placebo response, is it not?
Right. Yeah.
So even though they don't maybe like the placebo response, they certainly were taking advantage of it. But long term, and then I think, well, the side effects for all of us for overprescribing antibiotics, with bacteria being resistant for others, and also the killing off your good bacteria and all of that. And then I think, okay, well, then you could go into that, but that's a whole thing.
Right.
That's a whole thing to get into with somebody about why I understand you want a Z-Pack, but you have a virus.
But that's the point too, is that it shows how in order to try to improve the system, they're missing the boat. Because patient education is really the key to better doctor-patient interactions and the whole system working better. But the system doesn't allow it.
It doesn't allow it.
So they're trying to figure out other ways in order to try to make that happen.
They're trying to hack it.
Exactly.
And there's no hack for a good relationship.
No.
To really, there's no shortcut. There's no Yeah, that's so interesting. And then hearing you talk, I think, all right, so these guys that are running the money, the C-suite people are trying to find a way to measure so that they know that their organizations are doing a good job, which is totally understandable. So that's how they're doing it with these patient satisfaction surveys. And then I think, well, why can't they just like take a little field trip and hang out with some of their doctors? I used to have that thought all the time about maybe not meeting a metric at work. I didn't do enough shots or whatever I didn't do enough of. And I would say, I would love for them to come down and spend a day with me. Wouldn't their eyes be opened?
Yeah. And I mean, but they're too busy and they're too important.
Busy. Yes, they're very important. And they are crunching the numbers up there and coming up with more ways to make our lives hard with the best of intentions. I would assume the best of intentions. Yes, that's so great. Any other comments on that post that we really liked? He got a lot of comments on that.
Yeah.
And the people that make the surveys, some of them were commenting about how great they are and how necessary. Fantastic. I mean, it was a really kind of balanced discussion, I thought, of people that did not like them and found some problems. And then the opioid discussion came up. And of course, it always comes up in Ohio. And we'll touch on the influence the patient satisfaction surveys may or may not have had on the opioid crisis. We'll touch on that. Yeah, good stuff. Okay. Now we will talk about some benefits.
Right.
Okay. Feedback for quality improvement. Okay. Yes. I mean, how else are you going to get feedback? Unless you've got, which would also be a great idea, have somebody with a microphone in the parking lot and having a conversation. Then you could really get some feedback. But it would be hard. That would be cost prohibitive. But yes, you're going to see things from their perspective. Yeah. And I liked that. Like, I remember when they said, oh, we're doing these satisfaction surveys. And one of the things they asked was cleanliness of the waiting area. And I'm like, dang, when I'm coming into work, all I can think of is getting that gate open, figuring out what I have to do. And then it forced me to stop and look at the waiting area or maybe by the counter, the cash register through their eyes.
Right.
And then you see that doesn't look so nice. So that's a good thing.
Definitely.
To look through someone else's eyes.
Yeah.
And then people, I mean, that's a part of design of like apps. You're always thinking of the end user.
Of course.
Yeah. So I think it's good. I think it's good we think of the end user, how they may perceive it. And I had that thought too, the one time that I was taken into the emergency room by a stretcher and I got to see nothing but the ceiling. And the ceilings were so dirty. And I remember thinking, they should paint some butterflies on that ceiling. Of course, I was loopy on trauma, but just seeing something through other people's eyes.
But I guess
I like that.
I guess, and I'm kind of afraid to speak this into existence, but the other side of getting away from the patient satisfaction surveys would be them directly monitoring patient visits with cameras inside the appointments.
Yes.
Then they could get real metrics.
They could get real metrics. And that is like kind of goes with what I say they should just hang out and visit, which is a different energy than being monitored. That's very stressful. Of course, I guess you could feel monitored if someone is there. Oh, wouldn't that be dreadful? And they would do it.
Big Brother.
I know. Well, Big Brother's already here. And they would do that. That is frightening. And then the other benefit, patient-centered care. That goes along with that. Like if you're looking through the eyes of the patient, then you're going to want the care that you give in whatever system, office, to kind of be centered around that person. And I think that's good. Mm-hmm. And the thing that comes to mind for me is birthing suites, because I think the generation before I had my kids, it was pretty sterile and you were knocked out and strapped to a table. And I don't think that it was someone sitting in an office or even a doctor necessarily that said, we should change this up. I think it was the mothers, the people that gave birth that said, we want to do this a different way. So we're either going to do it somewhere else or you're going to change.
Right.
That's what I think happened. And so that I think is a very good thing.
Definitely.
To have the patients drive the system and make it more about what makes them comfortable. That's not going to happen in every single situation, obviously.
Right.
But
yeah, I mean, it's funny how that's such a novel concept in conventional medicine, patient-centered care.
I know. Not for you. That's your entire practice.
Exactly.
But for them, they need a word for it.
Right.
You're just doing your thing.
Yeah.
We have to reinvent, which, again, it's so ironic to me.
I know.
How could it be other than?
Right. But it comes down to just listening to the patient. I know. And that's what we talked about.
All the time.
They don't have time, but you don't have time. But if you're able to ask questions and good questions to the patient, but then also leave time for them to ask questions so that, and give them time to actually think about it, not as you're running out the door, do you have any questions? But actually give them a second to think about it.
Yes.
So that they can reflect on the discussion, the diagnosis, the treatment, and make sure that they have everything that they need.
And you can't do that in 6 minutes or 12 minutes.
I know.
So that, I guess if they really wanted to change things, if we really, I think, dug into this data and looked at it, then if they were taking it to heart, they would change the system in that one way. You get to spend more time with your doctor.
Yeah.
That's not happening, though.
Well, because it can't. Because
the money.
There aren't enough doctors.
Oh, that too.
Yeah, there's a shortage, so
but
they
there's
can't
a shortage
find the
because
doctors.
nobody wants to practice like this.
Correct.
It's soul crushing.
Yes. So, yeah, it's one of those self-fulfilling prophecies where the more you try to restrict and try to utilize the doctors that you have, you end up making them hate medicine more. And so they leave more and you have less doctors. So they're more busy and they hate medicine more. So.
Well, and the same thing's happening in community pharmacy. Yeah. That's why they're cutting the hours and saying there's a shortage. And I don't know so much there's a shortage, but it's just you can't practice like that and try to do a million things. And you're so terrified and burned out and it's just awful.
Yeah. So we had looked at a article from the Family Practice Management Journal in 2022.
Very recent. Yeah.
Yes, not too far back. And their take on what patients really want, they want strong communication, tailored care, and an efficient workflow.
So they want a naturopathic doctor. That is what they want.
Right.
But is really an MD. Yeah. Right.
So even if it's that the MD actually pays attention and then prescribes their drugs.
Right. Okay. So if the surveys are telling the higher-ups that, then we should see change rolling out at any time. But it's 2024 and this was 2022. Change takes time. The wheels of change turn slowly. Yeah. The ultimate goal is for patients to feel heard, respected, and supported.
Yeah.
So simple.
It is.
But you already know that. Yeah.
Well, that's where when we're working on this topic for the podcast, it's kind of hard for me to relate because these surveys are, like I said, a top-down. It's the management trying to understand what the doctors and the staff are doing, where when you have a small naturopathic clinic where I'm the management and the doctor, and I'm interacting with any other staff member, I know what's going on.
Exactly. You as the management know what you as the doctor are doing.
Right.
It's that tight relationship of being the one and the same. Yes. Yes. Very good point. Very good point. And you did touch on this before. Another benefit is performance benchmarking. And I guess I would have to agree that I am not opposed to having no metrics. Things need to be measured.
Yeah.
We're all in science. You measure things. You don't just hope and wish. You measure what you're doing. So I'm not opposed to all of it. I just think we've gotten carried away and made too big of a deal. So I think that that's good to have some sort of basic benchmark.
Right.
And then those benchmarks can go on the Google and everyone's looking to see how their doctor is rated and whatever. Not that they necessarily understand who's doing the rating or whatever. But I remember looking after my car accident a few years ago and I needed a plastic surgeon to fix my broken nose. So I went on the Google, but I did the opposite. I was looking for the guy or girl that had reviews that said really bad bedside manner.
Really?
Yes, because not making friends.
Yeah.
I'm not hiring a PCP.
No.
Okay, so a guy that goes into surgery and who's really good at surgery probably isn't the hold your hand kind of guy,
Right.
or he wouldn't want to interact with people that are unconscious.
Yeah.
And I found the crankiest, oldest, most experienced guy I could.
Mm-hmm.
And when I met him, I just brought myself to that, not expecting him to be nice or polite or any of that. And it was so liberating because I knew why I was hiring this guy. And he wasn't any of those things. And I think the fact that I knew that, and then like when he would like smile or do or say anything, and I'm like, yeah, he's a human in there.
Mm-hmm.
But why would we rate that guy the same as we would rate, like, I don't know, pediatric oncologist,
Yeah.
right? Who has to talk to children and talk to their parents and be in these really horrible situations. This guy is doing something miraculous
Mm-hmm.
while someone's unconscious. It's different.
But the other side of it, and we'll go into when we talk more about the pitfalls
Mm-hmm.
of these surveys, is that people typically only fill out the surveys if they're really, really happy or if they're really, really upset about the experience. And when you're talking about surgery, you have a much higher likelihood of having something bad happen because it's such an invasive procedure.
It's, very violent. Yeah.
And yours was for plastic surgery for your nose.
It was just to fix my nose.
To fix
Put
your
it
nose.
back to its
Right.
original horrible thing. But at least it wasn't broken. Yes.
Well, but that also comes down to the vanity part of it too, where people are paying for plastic surgery.
Mm-hmm.
Granted, you were different than maybe a lot of his other patients too, where they're looking for perfection and
That's
that he can't actually ever give them. And so when he does the best that could be done, it's still not good enough.
Yeah, that's really interesting. And thinking back now, I'm wondering if I were to be given a patient satisfaction survey on this particular surgeon, I wonder if they would ask what his bedside manner was like.
Yeah.
And then, I mean, I'm in healthcare. I would say it's good to give him a good rating because I was overall satisfied.
Mm-hmm.
I don't know that people are really thinking about that.
Right.
I don't know. But yeah, it's a really good point. Really good point. And then, of course, to go along with that is the regulatory compliance and accreditation, right?
Right.
Where Medicare and Medicaid want certain guidelines met. And in order to enforce that, then they can jack up your reimbursement.
Mm-hmm.
And with us in the pharmacy, they want a certain amount of the patients. Well, they want the patients to have 90-day fills.
Right.
Okay, so they need 4 fills a year, right? And then they want them to be picked up on time, which, okay. So they have all the medications they need. That doesn't guarantee that they're taking them, but at least it's something that they can measure,
Right.
right?
But what about the medications that need to be changed then if you're trying to push people to always doing 90-day fills and
People have a backlog.
I'm sure.
Because they want it, and then they want it filled early, so patients will say, I have a drawer full of pills. I'm like, I don't know what to tell you.
Yeah.
Like lisinopril, atorvastatin, things like that. But at least it's measurable. So if you don't have that, then they can take the money away, change your reimbursement. So there's a lot of pressure to do something that may or may not reflect what's really happening with the patient. I mean,
Right.
I mean, we do know that if people take their blood pressure medications regularly, then they have less problems with high blood pressure.
Correct.
So that I can get behind.
Yeah. And if they have a 3-month supply, they're not going to run out of their medication as often.
No way, no how. Right. And then also empathetic to people that can't get out as often.
Mm-hmm.
And they might not know that you can get a 90-day supply, and that might make them, make them feel better and make everyone feel better that they have enough. So I guess I can get behind that.
Yeah. But just linking reimbursement to those scores is just a scary thing.
Mm-hmm.
And just forces, that's where, like we're talking about, it's forcing people in the system to really focus on those scores so that they can get better payments. So the hospital, the doctors, everybody has to get better scores so that they can get paid more.
Right. I don't hear patient in that, any of that.
No.
Right. That's a problem.
Yeah. And I mean, in my profession, of course, that's always a concern. When we're taking cash and people are expecting,
Sure.
I'm the doctor and I'm the pharmacy.
Right.
So-
Recommending the supplements, dispensing them. Yep.
Right. So, I mean, I guarantee there are natural medicine practitioners. I'm hopefully a lot less NDs than other natural medicine practitioners, but a lot of people I'm sure are looking at, well, oh, look at all these different diseases this person has. I can recommend this and this and this and this. It's almost like what I see with the I can't think of the name of it. The people through the Cleveland Clinic.
Oh, yes. Functional medicine.
Functional medicine.
Yes.
Yeah. I mean, the patients come away with so many pills from the functional medicine doctors, but I just always focus on what the patient really needs and being mindful of their pocketbook too, because for me, if I overprescribe, then the patient can't keep up with the treatment, so they can't keep seeing me. And so it's a lose-lose for me and the patient. So I feel like the way I approach it is that I try to, I mean, obviously I'm an honest person. I'm trying to do what's most important for the patient and not try to rack up extra payments. But also when I'm looking at these kind of things, I look at the worst case scenario, and nobody on the outside can see what my morality is. And so when I look at, okay, what they can see is that if I recommend too much and they can't keep up with it, then they're going to leave. And that's where they can see it.
Yeah. And so you have a built-in feedback mechanism.
Right.
And that's really interesting what you said about being the manager and the clinician. The manager wants to see a higher bottom line for the practice.
Yeah.
But the clinician is also very aware, like we said, looking through the other person's eyes. Can they afford this? Does this make sense? Will they not be able to keep up?
Right.
That is so interesting.
Yeah. And so, I mean,
because your system's pretty simple, that you are one and the same.
It is.
Versus all of the layers in healthcare.
Right. And if I were to get to the point where I started thinking about the money first, that's when I know I need to hang it up, retire, get out of it. Because
if the system was like that, we'd be gone now.
Right. Yeah,
right.
Yeah.
If somebody said, well, as soon as we're sitting in those boardrooms and as soon as we start thinking about money more than patient care, we should all just hang it up. And they laugh and laugh. Yeah, but that's so great. So you have that like internal check on yourself.
Right. And I would say that if anything, I end up sometimes doing too little because I don't want to overburden them with those extra pills.
Yes.
And so I try to be as balanced as I can and look at what's most important, what's going to help this patient get the best, the quickest. But also there's times where I know, okay, this patient cannot afford that.
Right.
And so I want to look at something less that is at least going to give them benefits, but not move them forward as quickly. And I would say that would be my fault, is that I don't always loop them in on that part too, because I also don't want them to feel
a certain way. Right. Yeah.
Which goes with these satisfaction scores too.
Right.
But yeah, you don't want somebody to be down. Oh yeah, I'm poor. Yeah, doctor, I'm poor and I can't afford this.
No one's going to say that.
No
one wants to be humiliated.
It's funny though. The people that have the most money are the most likely to say I can't afford it.
Yes, I've noticed that in pharmacy.
People that are on lower income, they don't want people to realize that or look at them differently because they don't have as much money.
It's a status thing.
Yeah. Where the people are rich and they know they're rich. Who cares? It's easy for them to say, I can't afford this and I'm not going to pay for it. Right.
So interesting. And now you're reminding me of times in the pharmacy where I've talked people out of their medications, like even in front of the managers. They look at me like, what did you just do? But I knew that it was in the best interest of the patient. Like, of course, was always cognizant of meeting my metrics, whatever that took. Like, even if I worked extra or whatever. But like you said, sometimes you just know that you should say something that may dissuade someone from going down this path of a medication that's just not going to be the best for them. And I always felt good about that because that's how I check myself too. Like, who am I doing this for? I'm doing it for the man, but I'm also doing it for this person in front of me and my license. And I'm sure you think about your license. You took an oath.
Yeah.
So did I. Yeah. And I wonder if the doctors feel that conflict too, because they took this oath and then all these other things are really running contra to that.
Right.
And they feel that tension.
Of
Who
course.
wants to live with tension?
No.
And in the workplace. I think I'm going to skip that one because that was such a great point that you made. Benefit, market reputation, and competition. So this is just where, again, these articles say that doctors have to be aware of their Google reviews and they have to be aware of how they're perceived. Yes, but I think you have to take that with a grain.
Oh, yeah.
I can't imagine being a doctor who's really out there doing the best they can do, and then somebody gives a bad review maybe for something that has nothing to do with them. And then that makes me think about you too, because, well, do you read your Google reviews, first of all? Do you encourage people to write reviews? How does that, because to me, like, that's the equivalent of a satisfaction survey.
Right. So every patient gets an email after appointments.
Oh, yes, I've gotten those emails.
Yeah.
Yes,
And,
okay.
so that they can do a Google review. And I definitely look at all of them. But I also...
Do you take it with a grain? Or do you ever get like mad or upset or?
Well, only one time.
Okay, why?
But it wasn't even a Google review. It was on Yelp, which of course people don't look at healthcare providers with Yelp. And this person did that review on Yelp because I only had one other review on Yelp where I have a 5-star rating on Google with a couple hundred reviews. So they went to Yelp and to air their dirty grievances.
Yeah. Yes.
Now, mind you, they still later came back to me, but and I was a good enough person who is confident in my abilities and doesn't get hurt by that. I never mentioned it. I didn't ask them, oh, could you came back? You must really want my services. Could you rewrite that review?
But I think if you were that kind of person, see, again, that just tells me that you care more about their well-being than your own ego.
Right.
Which I think is a really, really good thing.
And that's the thing. I mean, yeah, I'm sure a lot of people in the medical system have big egos and it hurts, but
sure. I would think so.
Be an adult.
Yeah.
I mean, who cares if you're not going to make everybody happy? And that was something very hard for me to learn early in my practice when I had patients that what I did wasn't good enough for them, that they felt like I didn't do the best for them and they left. I took that personally.
Yeah.
Because I want to do the best for everybody. But it took really looking at myself and realizing that there's a portion of the population that no matter what I do, I won't be able to help them. I won't be able to make them happy. And so all I can do is focus on
those you can help.
Well, focus on, but I don't know which one.
That's true. You don't know initially.
I don't know.
True.
So
it's
about just doing the best I can and letting it all wash out. And
I love that.
The patients that aren't right, they're not going to come back.
Yeah.
And that's okay.
And that's okay.
Yeah.
I remember too, they would kind of tell us repeatedly, if you have a really good interaction with somebody, hand them this card and have them fill out a survey. I couldn't do it because I was having such a moment a lot of times when even it was not even a moment, it was 45 seconds. I knew I was getting through. I knew I did something good. I knew I had a connection. And now I'm making it transactional.
Right.
I didn't want to do that because I didn't want them to then walk away with, oh, is that why she was so nice to me? Was that really true?
It cheapens the whole experience.
Yes. And I would never do it.
Right.
Never.
Yeah.
Yeah. I too had a bad review once and I knew it was coming. So I went to my boss. I'm like, listen, if you're going to put me in front of all the difficult patients, because he wanted to really stand back, I'm going to swing and miss sometimes. Mm-hmm. So up to you. If you'd like to get on my case about this, that's up to you.
Right.
Smart guy, he didn't. Because you are going to miss. You're going to swing and miss. If you're out there trying again and again and again and really putting yourself out there like you do when you care about people, you're gonna miss.
Yep.
Oh, all right. So now, pitfalls.
Which I think that's all we talked about already.
Well, that's what I mean. I feel like so much of it isn't so great, except for seeing things through the eyes of other people.
Right.
And then I guess if you were a patient and you're looking at the Google reviews or whatever, just take it with a grain of salt.
Yeah.
Or maybe do what I did. Like if you're looking for a surgeon, think about what kind of qualities you really want.
Mm-hmm.
You're not interviewing for a best friend.
Right.
And when you hear these really fluffy reviews and she was this and she was that, I'm like, well, I don't need that. I might need that in a friend or a confidant, but I don't need that in a doctor.
Right.
Kind of thing. So I guess that part is good, but I don't think much is good about them.
But that's also, that brings up when you're talking about not needing the doctor to be your best friend.
Right.
I often have the conversation with patients who don't really care for their doctor, that they want to, can I recommend somebody better? Mm-hmm. I always bring it down to, do you feel like they have your best interest at hand and they're trying to do the best that they can?
Oh, I love that. Those are questions that should be on surveys.
Right. Because if they're trying, even if the patient's coming to me for natural medicine, even if the doctor poo-poos that, who cares?
Right.
Because they're going to them for a certain purpose with getting their diagnosis, their annual physicals. If they do have a disease, they need their meds and all of that.
Meds, yeah.
But then they're coming to me for the other part of it.
Yeah, I love that. And in so doing, then you also strengthen that relationship, I think, with the physician, which is great. Mm-hmm. And I would do the same thing, too, if people would say, oh, the office didn't do this. Oh, what do you mean the office didn't give me my refill? It would never be, yeah, that office, they don't care. They're so busy. It's like, oh, you know what? I know they'll get to it. They care about you. Always trying to reinforce how much. Like, because I think truly most people that get into healthcare, whatever branch of healthcare, do care about people. It's this other stuff that's really getting in their way. Yeah. And if we can just focus on what's important and you reinforcing that, I think is a beautiful thing.
Yeah.
So one of the pitfalls that comes up when we search this topic is non-response bias. And I think that's important. So a low response rate can lead to biased outcomes.
Right.
As the views of those who respond may not be representative of all patients. As you mentioned before, the really happy or the really upset.
Yeah.
And that's human nature.
Of course. For all surveys, for anything, any kind of feedback.
Yes.
And that's where, when we come down to these surveys, that's what makes them not that accurate, is because you can't force people to give feedback, but the only people that are going to give it are going to be the really satisfied and the really dissatisfied.
Yeah. So you're missing a lot.
Right.
So you're at the two ends of the bell curve, really.
Right. There was a study that we looked at, and we'll have all of this stuff in the description, a list of it all. But this study was barriers to participation in a patient satisfaction survey. Who are we missing? And it highlighted and looked at the people that are most likely to not fill out the survey are going to be people with language barriers.
Makes sense.
Substance abuse, cognitive limitations, psychiatric diagnoses, and sight deficiencies.
Oh my goodness. See, we didn't even think about that.
Right.
These people could be giving the system a wealth of knowledge.
Yeah.
And we're not even capturing them.
Right. And for different reasons. I
mean, all different reasons.
With like the substance abuse, it's because they're already ashamed of what's going on in their life and possibly their interactions with the medical system. So, of course, they don't want to highlight that. Yes,
that's a really good point. That's why that's in there. That makes sense. The rest were really evident why not. But you're right. That is why they wouldn't want to.
It's really unfortunate that this happens, but also it just comes to the bigger issue of patients being able to give adequate feedback. And with the people that are going to be least likely or going to be some of these populations that need the most care and need the most help.
And we should be then tailoring our services and our thinking about things through their eyes.
Right.
Great point.
Yeah. Yeah. So, like, for instance, when some of the people watching the podcast might know that I have 2 sons with autism. And our oldest, since December, it's late April right now, but since December, he's been going through some issues, and it's come out as behavioral issues.
Okay.
And he's basically, he really isn't able to vocalize. His speech is very limited.
His true experience, his internal experience,
Right.
you can only really guess.
Exactly. So, and he can tell us some of his wants and needs if he's hungry or he's to go to the bathroom, and a lot of that he struggles with too. We can't ask him. It's hard to ask him what he did at school. We can sort of push and push and push and get a couple of, oh, I went to lunch. Well, it's actually not, I went to lunch. It's lunch, gym, leisure time.
Yeah.
But so he's been having these behavioral issues pop up at school, which then worked into home, and having trouble at bedtime. And we're sort of grasping at trying to figure out what's really going on. And of course, you start looking at it mostly as a behavioral issue, but because we can't get the feedback and nothing has changed in his life, so we can't say, oh, well, this is a physical problem that is probably happening. But through working through all this a couple of months ago, he had times where he would have really a lot of trouble at night going to bed and thrashing around his bed, and sometimes even, hitting his head on the headboard out of frustration.
Oh my goodness.
And so I would come into his bedroom and try to calm him down and everything. And the one night I finally noticed that he was doing a lot of burping as he's flopping around in bed. And then I finally put it together that at least part of this problem is acid reflux. And so I was able to give him a licorice root supplement that I put in with his nighttime cup and in his morning cup before school that has supplements and everything in it. And a lot of the behavior went away almost instantly.
Wow.
It's like the next night he slept like a baby. He didn't have he was up for an hour prior and there was no problems then. And then the behavior at school has been getting better and better and better also.
That's amazing. And you could have never found that on a survey.
Right. This is even above the surveys. It's just about understanding the patients, especially these more vulnerable populations.
Right, that we're totally missing when we're trying to improve.
Yeah.
Assuming that that's the point, is trying to improve it because they just communicate so differently.
Yeah.
Yeah, that's a great point. We are missing all of that, really.
Right. And I guess in one way, I'm so grateful to have to be aware of that with my kids to help patients too, because
so you've like kind of have this skill set, this innate skill set of hearing what's not said and seeing what's not seen.
Yeah, like for instance, a good example is a patient that she's an adult and she has some special needs, physical and mental, emotional. And so she came to me for help. And at first I'm going by on the surface from what she's telling me and trying to treat with that. And then she comes back for her second visit and I start getting a whole different picture.
How so?
Well, some of the problems she was having were just really basic that nobody cared to really help her with. Like she was having foot pain. Well, when I was trying to talk to her more, because in general, when I'm seeing new patients, I will do a more general treatment with diet and some more general supplements to try to help, because a lot of times that's enough for a lot of people. We don't need to get real specialized. But so she came back, and so I'm asking more questions and about her foot pain. And well, it works. She's a hostess at a restaurant, and it hurts so much walking back and forth during her shift. That's where her foot pain is really coming from. And the more I question and trying to understand this, one of her shoes doesn't fit.
Really?
Yeah. And so her feet aren't the same size, and
Right.
she needed one shoe that was a little bit different size, and that made all the difference in the foot pain.
Oh my goodness. And all I can think of is she needs gabapentin and Percocet, right?
Right. But then it didn't stop there. She was having incontinence issues, and she's an adult in her 40s, and her mother takes care of her, but she's having incontinence issues, and the mom was yelling at her for having accidents. Well, nobody ever talked about, well, what about pelvic floor exercise to strengthen to help with bladder control, because she doesn't want to do this. She's not doing it on purpose. It's that she can't help it.
Yeah.
And so it's about getting the physical therapy and a lot of other, and just the more I started going through with this patient, a lot of things it wasn't stuff that I could help with necessarily.
Right.
But trying to help troubleshoot, because nobody else would, to understand how can we make her life better and also help her to survive when her elderly mother can't take care of her anymore. She needs to be getting some occupational therapy, some independent living skill occupational therapy to help her with her physical disabilities to be able to do things different so that she can do things by herself.
Yes.
And so that was really eye-opening there. Because, like I said, she talks well, and at first I didn't really grasp
what the real problems
were. And it just made me appreciate that. Well, for one, it made me sad that our primary care is never going to be able to do this or even pay attention enough to be able to help her. But
because of the system.
Right. But it's just basic things that people that have some of these deficits can't troubleshoot themselves, and they need other people to help them.
They really do need that.
Yeah.
And like you said to be the beginning, if the system is rush, find the quickest thing, get her some Ditropan for that, get her some gabapentin, pain gone, satisfied patient, and you've missed so much.
Right.
You've missed all of it, really.
Yeah.
Yeah. Wow, that's sad. That makes me sad. And no doctor wants to practice like that.
No, but that's the thing too, is a lot of people that have mental disabilities, people feel uncomfortable around.
That too.
And I think that's a big part of it, that people don't feel comfortable. So that it's rush, push through.
Which is that's the system anyway.
Right.
That's
right. But even more so that people feel uncomfortable around people that have some of these special needs.
Which that might be a good use of resources.
Right.
To do some like training around that.
Yeah.
Right. That's even deeper than the next pitfall, which is patient understanding. Like that's a different level of not understanding.
Right.
And there are patients that don't have medical understanding.
Right.
Like they don't understand that a Z-Pak or an antibiotic won't kill a virus. They just don't understand that.
Right. But they've been receiving it their whole life. So anytime they get a cold or a flu or something, they go to the doctor to get their Z-Pak.
Right.
Exactly. Because that's what you're supposed to do.
That's what you're supposed to do. Or that they just are focusing on something like wait times. Even the people themselves are forgetting why they're there.
Right.
So that they can down the road be better, get well.
Yeah.
And then they might focus on being irritated about a wait time, which could ruin the survey. They just don't understand.
Right.
Yeah.
Well, it's because that brings out frustration and brings out more of those feelings that the system doesn't really, this office doesn't really care about me.
Of course.
Because,
and that's understandable.
Right. Because they should be understanding about my needs, and that my time is money also.
It's true. They're not wrong.
Right.
Yeah. Right.
Yeah. And so talking about the patient understanding, we found a Mayo Clinic online physician review reflecting about these patient experiences. And a lot of them are going beyond the physician-patient interaction.
Yes.
And doing things, as issues with the staff, the environment, or billing, not as much, not always about the actual doctor or the nurse.
Which has got to be frustrating.
Right.
And I know there was a couple practices when I was in a busy retail setting where the patients that came to me for prescriptions had the same complaint about the same office staff member. Well,
Yeah.
it's the person that answers the phone. They're so mean. They're cranky. They're this. They're that. What are we really going to do about that?
Right.
I mean, and that goes to kind of what you're saying is, should energy and time be spent with dealing with workplace conflicts and how to be compassionate and how to treat people,
Yeah.
as opposed to this other, like maybe remodeling the waiting room because people didn't like the color on the survey. I don't know. Like
Right.
what
Put
nonsense.
in a TV so that people can entertain themselves while they're sitting there.
That's it. We have long wait times, but you can watch TV.
Right.
Wow, you're on your phone. We have a big screen and a little screen.
Yeah, we'll give you free Wi-Fi too.
Oh, yes, that'll solve everything. Which then again, that kind of goes into how it becomes resource. And there's a lot of money is spent on these surveys.
Right.
Designing them. Probably third parties have to come in, right, administer them, analyze the data, and that costs a lot of money. I would love to know how much that costs.
Oh, yeah.
I would really love to know that.
Yeah, it's just set up initially, and the same surveys keep going out automatically.
But someone's analyzing them,
Right.
and looking at the data.
Definitely.
Yeah, that's true. That's true.
Yeah,
So
but
maybe it's
it all gets sent back to Press Ganley, and they can do
Okay.
what they want.
right, or are they analyzing it? Right.
Right.
They've done it. Well, they would have to analyze it so they could publish the results, I guess, or at least present it to the board.
Right.
I don't know. I feel
But
like
yeah, that does put extra on everybody,
yeah.
because I'm sure that the staff, and that's the thing. Like I said, I'm so out of the system that it's hard for me to know. So how do these surveys actually go out to patients?
That's a really good question. I don't partake of the system myself.
Right.
And I'm trying to think like, okay, so at work, when I worked for corporate healthcare pharmacy, we would give them a little
Right,
or
right.
put it in their prescription bag.
Yeah.
I don't know if they probably get text messages now to fill out surveys. I don't know.
Get
There's
something in the mail or who
Something,
knows.
yeah.
Because it has to be automatic.
Has to be. Can't have all that, spending all that time.
Right.
Yes. Yes, I love the one about prioritizing amenities over essential services, because I think you brought up some, especially the one about the underserved population, people with different kind of needs,
Yeah.
that energy could be put there versus TVs.
Yeah.
But that data is never going to be uncovered in a survey
Right.
for the aforementioned reasons. Yeah, I really like that. And then overemphasis on scores. See, this is where it just makes my heart hurt to realize how many years I practiced like that. You're just like kind of striving for a number just to
Yeah.
get the bosses off your back.
Mm-hmm.
It's not why we got into healthcare, but you
Right.
touched on that before, why doctors are leaving.
Yeah.
Because it's not about why they got into it, which is really to help people.
Well, exactly. Yeah.
I
And
don't want to overemphasize those scores, but I always laugh. I have nurse friends who they're like, and now I got to ask the patient satisfaction questions. I have to ask them, even if it's inappropriate.
right.
Even if the 5-minute interaction, this beautiful interaction I had with this patient, when I ask these questions, it's going to ruin everything.
Right.
But you can't, so you bring that to your manager and they're like, the nurses would say, but you have to ask the questions. And then the managers might say, well, the nurses are saying, and then their higher ups say, but you have to ask the questions because that's what we're measuring. And,
Right.
and then the whole thing is lost. So the one nurse friend I have, if it comes down to it, they're like, so I make up a question. I pretend I asked. I mean, but what are you going to do?
Yeah.
Because you can't, if you really care about people and you know where this interaction is going to end on the best note for that patient, and you don't want to ask these foolish questions.
Right.
But if you don't ask the foolish questions, you may lose your job down the road. Then you won't get to have that interaction.
Exactly. Yeah.
Check, check, check,
Yep.
check. I'm not
Yeah.
saying
You
I
have to
wouldn't.
do it. Yeah.
You got to do what you got to do,
Right. Right.
which is unfortunate.
It is. It is. But it just comes down to you have to look at all of the factors involved in being able to offer the best patient experience
Yeah, all
with-
factors.
and do what's in your control.
Yes, because there is only so much.
Right.
When you're in the front lines of healthcare,
Yeah.
there's only so much that's in your control. Yep. Yep. Yes. The scripted nurse interactions. Yes. There is nothing worse to me than having to say something that just doesn't make sense in the moment or in any moment.
Right.
Some
right.
of the things that I would say, they want
Yeah.
you to say, what?
Yeah.
So, yep. This is what they want me to say to my patients.
And
Oh my.
That's horrible. I mean, it sounds more like a Saturday Night Live skit than anything.
Yes.
You're going through and doing this great patient interaction and rate from 1 to 5 how this experience was.
Right. Or something that they've covered indirectly. Now remember to get your flu shot. Well, we just talked about this, and or whatever it is.
Yeah.
Just checking boxes to check boxes.
Right.
Versus it having some real purpose to it. Does your brother have to do these things?
Yeah.
Or this surveys and
Mm-hmm.
does it bother him at all?
It doesn't, because he looks at the patient experience the way I do.
Okay.
And
so he doesn't care about corporate metrics.
You go to university hospitals and go to his survey results, and he has 250, 300 surveys, and his average is a 5-star
That's great.
review.
But he does spend more time with patients.
Right.
He spends more time. He makes less money because that's the deal that he has.
Right.
And not everybody wants to do that or can do that.
but
But he has found a way
Right.
to make the system work for him
Yeah,
and
but-
for his patients, really.
But yeah, he has definitely, as I was talking to him about this whole
Yeah.
thing, yesterday, and I wish I would have written it down. He had just received his surveys from the last month that he had to look at, and I can't remember, but there were a couple of patient interactions where he got dinged on, and he's like, that's the way it is.
But he doesn't, like, the higher ups don't come down on him and say you have to change your ways, or
Well, no, because
there's enough good that's coming out
exactly.
of it. Yes.
It's the minority, and it's going to get buried in his really good scores.
Yes. And I think that he keeps that in perspective.
Right.
Because some of my peers in pharmacy, if they got a patient called and complained about something, they really took it to heart.
Mm-hmm.
And then if it's on their performance review, then it's even a double whammy. And they could be the best pharmacist ever.
Right.
So those things need to be weighed out.
Yeah.
So if I had, being the manager, a pharmacist that I knew was going to be so sensitive to that, I would, and I got a complaint, I would absolutely not tell them about that, because that's going to hurt them. But I think in corporate, you're so removed, you tell them everything.
Well, but it's always how you do it too. I mean, you can
Yes,
tell
this
them
is
and
true.
say, yeah, we have this patient, and this is the negative feedback we got. But it's how you handle it with that employee that makes all the difference.
It can be. And sometimes you just can't.
Right.
Like I had one, there was no way I could ever. Because no matter how I tried to, it would, but then again, that's a people problem. You have
Right.
to know your people.
Well, but I'm
you as
talking about-
management have to know your people. So if I got a
Right.
bad review on one of my pharmacists, somebody called and complained, there was at least one time I can think of, maybe two, where there was no way I could tell them this. But
Yeah.
I knew the situation, and I knew the circumstance. And I knew it wasn't a pattern.
Right.
I think that matters too. Like if it's going to be like, say I see something in a pharmacist that I'm like, yeah, this is one of these days someone's going to call and say, and because I'm seeing it, they're going to see it. Then
Yeah.
you would have to, because then that's going to make everybody better.
Right. Right.
But
I
it's
guess-
these nuances that get lost when everything is so corporate. Yeah.
But also, I mean, I guess I'm with my employees. I would talk to them about, say, yeah, this person gave this feedback, but you minimize that it's an issue.
Okay. Well,
You
I
know,
mean,
so that they get that
but
feedback.
your people,
Right.
you know your people.
Right.
Yeah.
Yeah.
Yeah. All right. But it is, I think it's very stressful. And even the state board now, the Ohio State Board of Pharmacy has come in and said to retail pharmacies, you can't be pushing these metrics down the pharmacist's throats. And part of the metrics is that, although they are also saying you can't make patients wait days and days for medications, because that was happening because being so overwhelmed.
Right.
So I think the overemphasis on all of this has created a real problem for patients, and at least the Ohio State Board of Pharmacy is looking into this. And
I guess what it comes down to also is, if it wasn't tied to Medicare and Medicaid reimbursements, then that would change the whole feeling of it.
True.
Then it could be a lot more objective.
But because we have this extra layer of the government getting involved.
Right.
Oh, boy.
Right.
Yeah.
Yeah, the government always messes it up.
It does. Yes, that's another layer. Talk
Right.
about being removed
Yeah.
from what's really going on the front lines of healthcare.
Yeah.
Wow. Yeah, that is very true. And there's really not much you can do about that. You kind of have to play that game, don't you, as a healthcare provider, if you want to get reimbursed from the government. And so many people have Medicare. Yeah.
But it comes down to all you can do is your best.
Right.
And if you really have the patient's best at hand and you do everything you can in your limited amount of time, the patients will appreciate that. And you're a lot less likely to get
a bad review. Yeah. And you had this one about the phones. I was thinking about the phones tied to the metrics. One of the big box stores would ask patients how many times the phone rang before someone answered. And then if it was 5 or 3 or more, then they would the pharmacy staff would get yelled at. Meanwhile, they're doing a million things when there's no staff.
Yeah.
But nobody cared because that number of how many rings, how many people said it rang too many times affected that's ridiculous. Talk about not seeing the big picture.
Yeah.
But that happened. Yeah.
Well, that's mind-blowing because that should be corporate saying, okay, we need to have more people on the phones. So the phone's not ringing as much, not saying, oh, these people are just goofing off.
That's a great point. What are we doing with the data?
Yeah.
Oh, we have data. Okay, that's a great point. Then someone has to analyze that data.
Yeah.
And then they've come to the total wrong conclusion.
Exactly.
Yes.
I mean, sometimes it could be people that are messing around. They're talking to their coworkers and ignoring the phones. But you also you should also be able to see that, well, then those phone wait times vary by the shift and by who is in charge of the phones.
Of course. It's a variable. It does change. Yes. Yep. Stress on healthcare workers. Yeah, that's where it really, really hits. But, and also, anything else about stress on healthcare workers that we wanted to say?
No, I mean, it's a problem because it is affecting their pay.
Right.
And, and creating all these extra layers of busy work that they have to do when they don't have enough time to see the patient.
So that ultimately is affecting the patients.
Right.
That's what we all need to keep in mind.
Exactly.
These metrics that your doctor is beholden to is affecting your care.
Yes.
Yep. And then another pitfall, I thought this was a really interesting topic that you had uncovered with your research, is gaming the system.
Yeah.
Yeah. That's where I think it kind of gets real. Avoiding difficult conversations. Talk about that. That's such a good thing again.
Right. Well, I mean, if you are totally focused on
this metric, this measurement,
and am I going to get the best reviews, and I need to get better reviews so that I can make more, so that I can pay off my boat or my kids' college or whatever it is, then maybe you don't want to talk about the patient's weight issues or smoking issues or alcohol or any of these factors that are really
Yep, that is avoiding difficult conversation. I would not have thought about that, but sure. You really need to tell them this, and maybe you've told them 15 times already, and this is the time they're going to get hit with the survey.
Right.
They're going to be mad at you. They had a really bad experience in your office.
Yeah.
The truth hurts and they didn't like it. Yeah.
It also can be for other reasons too. Like, say I have patients that, they don't want to take medications. And so maybe they're not seeing me yet, but they're going to their doctor. They have high cholesterol, but they don't want to they want to take the medication. So eventually the doctor is like, why should I have that conversation? And even more so if they're worried about their scores, because they're worried that these are the patients that are going to get more irate about me constantly talking about their cholesterol, and they'll give me a bad review.
Yep. And then also with kind of the healthcare providers trying to kind of game the system or trick the patient satisfaction system is, and I think Dr. Aman was pointing to this too, they'd prescribe unnecessary antibiotics, which we've hit on many times. They want it, so let's just give it to them. Is it going to help? No, but let's just give it to them. Pain medications when maybe they don't need it, which we can talk about that a little bit. And then unnecessary tests. They really want this test. They really want it because they don't really understand why they don't need it.
Right.
and they're pushing so much. You just like, all right, give them the test. What's it going to hurt?
Right.
What hurts the bottom line?
Yeah.
Right. Then they're spending too much money.
Yeah.
Yeah. So we get antibiotic resistance, opioid dependency, increased healthcare costs, which is the last thing we need is on increased costs. I'm talking about from a corporate perspective, the people that have come up with these surveys.
Right.
And the opioid dependency, so prescribing unnecessary pain medications, which became a problem. And that was touched on several times in that LinkedIn post we referenced in the beginning. I don't think that I think it was a bigger problem than gaming the system because there was other issues that were pushing. Well, if there was no pain score, if we didn't change pain from a symptom to a disease, right, then we wouldn't have been measuring it differently to begin with.
Right.
And like when I was in my truck accident years ago and we had discussed pain and how I was going to manage it. Ibuprofen, you'll be fine. He writes me a prescription for Percocet. I'm like, I don't understand why you did that. I have to ask because I'm so interested in the opioid crisis and I'm a pharmacist. He said, because we have to.
Right.
Because if I don't, then I get a little ding because I didn't give you proper pain control.
Yeah.
But you did. You said I would be fine with ibuprofen. He's like, you don't understand.
Yeah.
And I didn't know they had to do that.
Yeah, I mean, I remember having a tooth extracted.
Okay.
And got prescribed Percocets for it. And I didn't even want to fill the script. My wife was like, well, just in case you need it.
Sure.
Yeah, we don't want you to be in tons of pain in the middle of the night and not be able to get to the pharmacy. So she filled the script, but there was no way I was taking it.
How many did they give you? Because back in the day, it was like 30 or 40. Now they're a little more careful. Well, there's rules. They can only do 3 days. Yeah.
Right. It might have been 3 days. This is, I don't know, 5 or 6 years ago. I can't remember how much, because I didn't need it. I didn't care. So it didn't matter to me how many were prescribed.
Exactly. I framed my Percocet prescription. I'm like, this will be the last.
Yeah.
Yeah. I wasn't going to get mine filled either. Yes. But yeah, you can see how just to give them what they want, get them out the door. Again, not thinking, not asking a question.
Right.
Do you have addiction in your family? Do you, just write the script.
Yeah.
Like, wow, this is a much bigger, more complicated issue. But if you're only focused on that one metric, that one piece of the survey, you do something you wouldn't do were it not for the survey.
Right. Exactly. And that definitely, I'm sure, fueled a lot of the opiate crisis.
It did. It wasn't the cause, though. Yes, but it did fuel it. Yeah. Yes. And then we were going to talk about overemphasizing on patient pleasing. And I think
which goes along with a lot of those same things.
Exactly.
But it also goes into paying more attention to things like wait times and the luxurious amenities and things like that, as opposed to good, solid patient care and taking care of their problems so that they can get over it.
That's a lot of common sense right there.
Right.
You just summarized the whole thing, Ted, right there. Yes. And that goes into maybe resource misallocation.
Exactly.
And we touched on that. Like, so we're going to buy a fancy new waiting room where people are waiting a long time, but at least they're comfortable. They have a massage chair and a nice TV versus like training for dealing with underserved population, which would be a much better allocation of resources. Right. And then hit on erosion of trust. I would not have thought about that.
Well,
that's huge. That's like thinking long term.
But that's also just what we were already talking about when you didn't want to give that patient the survey after the interaction, because that does erode that trust.
Because then they wonder why. They question my intent.
Exactly. Your intent and your integrity. Oh, okay.
Yes.
This person's only being nice to me because they're trying to get good survey results. That maybe they'll get a bonus for that. And they didn't really care about me.
That's awful.
It is.
That's really awful.
Yeah.
Because if you don't have trust, if you don't trust your doctor, and that is, to me, integral.
Right.
To wellness and healthcare.
But another one that I think is even more important than that is avoiding challenging patients. So maybe you don't accept the patients that are going to be more difficult because they are going to be a lot less satisfied. So I can pad my schedule with the easy patients, but not worry about the ones that are having a lot more complex problems, because of course they're not going to get better as easy no matter how good a doctor you are.
You're right.
And you're going to get more feedback that's negative, no matter what.
So again, you're missing a big chunk of the population that really needs you.
Right.
Oh, that's a problem.
Yeah.
Yes. Yeah. I mean, ways to so manipulation is a big downside. So how do you mitigate that? How do you mitigate the effects of manipulation? I mean, again, we're talking about really an overhaul of the system.
Yeah. There's no other way.
We have to overhaul the system, and the only ones that can really do that are the people that are running the system, which are not the doctors or the pharmacists or the nurses.
Because they're also worried about the bottom line, and that's it.
The people that are running the system.
Yeah. And so I guess, that takes us down a whole other rabbit hole.
It does.
With this, because...
Yeah, which I don't think we need to go down.
Well, I think a little bit.
A little bit?
Yeah, because when you look at corporate behavior...
Oh, let's. Can we look at corporate behavior? Let's.
You look at any corporation, the CEO is only focused on the next couple of years, maybe the next 5 years, tops.
Yeah.
They're, and probably more so just the next year, with making sure that our stock price is doing as best as we can for the dividends and everything.
True, because the answers to the board.
Right. And so they're not looking at long-term benefits. They don't care about that because I'm going to be gone by then. Very true.
So, that's a problem in the system.
Yeah. And that's why the system won't ever get fixed.
You're right.
Because nobody's in it for the long haul. The people that are high up, it is just a short-term gig to be able to get to their next thing or to retire.
Right.
And
no, you're right.
if they put in too much work, then they're spending too much money, their stock price starts going down, and then they get fired.
Yeah. Yeah. It is a systems problem.
Right.
And who gets hurt is the patients.
And the doctors too. The whole, the staff. It's the corporate and the management that are insulated. That's
true. And there is really a lot of pain in the system. I can tell you that.
Yeah.
That's why I went out. Yeah. It's a very painful place to be for those reasons, and many that I think patient satisfaction surveys. What's interesting in talking about this is we really did get to touch on what's really wrong with the system, where it's so reflective in the problem of patient satisfaction surveys, which is beyond what I think most people think about when they think about patient satisfaction surveys.
Right.
It turned out to be such a good topic. Is there anything else that we wanted to say about mitigating manipulation?
No, I mean,
because again, it's not something that you or I are going to solve.
Right.
Or anyone at our level. Yeah, patient satisfaction surveys, the good. We talked about so much that's bad. Anything else we want to really talk about? How would you rate this podcast, Ted? Let's rate the podcast. What do you think about this podcast on a scale of 1 to 5?
I'm always good at rating everything out of 5. So
out of 5.
I'm
You're
going to
so
rate.
Satisfied.
Of course, I'm going to rate our audio, our video, our knowledge, our experience. Everything is going to be a 5.
Everything's a 5. What do you think, Todd? How would you rate this podcast? Are you satisfied?
Of all the podcasts I've ever seen, this is definitely one of them.
This is one of the podcasts
That's right.
you've seen.
You're not going to get a survey, Todd. No survey for you.
Oh, I think it's 5.
I love it. Okay. Anything else we want to say about that? We're going to link all of the stuff that we talked about.
Right.
If anyone wants to do a little bit of a deeper dive.
Yeah. So I just have a couple
you have really good final thoughts here.
I have some final thoughts here.
I didn't see these slides that you snuck in here. Please.
Yeah. So when it comes down to patient satisfaction surveys, and we touched on this, but not in a lot of detail, it comes down to they can't be accurate to begin with. I mean,
man, that's what we've come away with. You're right.
Right. Because we talked about the non-compliance, and not, the bias.
Yeah.
But also even more so, and just like I was alluding when you asked me about how I would rate this podcast, I think that most people, when they're doing a survey, there's a couple of factors that fall into that. There's one known as social conformity bias.
Ooh,
And so that's where people will answer based on what's the most socially acceptable answer. And they tend to downplay undesirable attitudes while inflating the more desirable opinions and attitudes.
That's just human psychology.
Right. And then another one, acquiescence bias, which it's very similar, but it's basically when you're asking somebody for a survey statement, they're always going to agree.
Okay. And we have studied that. They've done social studies on that. Yeah.
Yes.
Okay.
Yes. But looking at all that and the psychology of it, what do we expect? Because
Right.
when you're answering a survey, there's a lot of different reasons why you're just if you're going to actually do it, you're just going to give all 5-star ratings.
Just to get it over with, really.
Because maybe you don't care about the questions. It doesn't really...
You didn't read the questions.
Right. Or it just doesn't impact you.
Sure.
I mean, I think about when I was especially in medical school, not as much in undergrad, but at the end of the semester, you're always rating the professor.
Oh, yeah.
No matter whether I liked them or not, I couldn't give them really bad ratings because they're another person and that could harm them.
Right.
And I think that's what a lot of people look at too, is they don't want to harm their doctor or the doctor's staff because even if it's not the best care, they have a relationship with them. Have a relationship. And they're going to downplay some things unless they feel really harmed. Yes. And in general, we don't like to be confrontational.
Well, it's why the doctors avoid hard conversations. Why we all avoid hard conversations.
Exactly. And the last thing I want to say with the psychology of this is that by admitting that our doctor isn't doing an amazing job, people look at that. They don't want to admit that because, well, then that says something about me.
Oh, wow.
About my intelligence and about my decision making, why I don't have the best doctor out there.
Yeah, that's very interesting, isn't it?
Yeah. Yeah. And so then I want to have this video that we saw, at least this portion of it. I just find it fascinating because this doctor who I don't know who he is, he's on YouTube and he does lots of stuff and I'm sure a lot of really good stuff too. In fact, I saw when I was looking at Corey Amon's LinkedIn that post, he linked a different video of this guy's too.
Oh, he did? Oh, yes. I missed that. Okay.
But anyhow, so this doctor on this big whiteboard is going through how the Prescanley scores are tallied and what they all mean and how it gets rated. And when it comes down to it, doctor scores the worst doctor scores are about 70%. And the best are about 91. So his total takeaway is that why are we complaining about this? People love their doctors and you should just shut up about it because it's not doing anything. You need to understand that these surveys are accurate and people love their doctors.
Oh, wow. Maybe he should watch our podcast. Oh, my goodness. Yes, we'll have that link as well. And thank you all for listening and watching our podcast. And be sure and click whatever button you have to click to follow and so you don't miss an episode.
Thank you for joining us for this podcast. Mary and Dr. Ted want to remind you to use the internet wisely and to always be sure to consult with your medical provider with any questions or concerns that you may have as you work towards your wellness goals. We look forward to sharing more content with you soon. Thanks for listening.